So good morning, everyone. Aryan Doshi, CFA, an equity research analyst from Divisha Investments. I welcome you all to the Divisha Investor Interaction Series. And for those joining us first time, Divisha is a SEBI-registered research firm founded by the investors for the investors. And today we are looking at one of the most exciting investment themes in Indian healthcare right now, the GLP-1 opportunity. Now, quick disclaimer before I start. This is just for an educational purpose and this is not an investment advice. We or our clients may hold positions in the stock that we discuss. Okay, so before I even start, let me ask a question. India, 1.4 billion people. How many do you think are diabetic? 10 crores. That's diagnosed. And on top of that, 13.6 crores are pre-diabetic. So you add it up, 23.7 crores Indians dealing with diabetes in some form. That's more than the entire population of Brazil, just in diabetes. Now, there's a drug that was originally made for diabetes, but it turned out patients started losing 15 to 25% of their body weight. Then trials showed it reduces the heart attack risk, the fatty liver, and then kidney disease. One injection, once a week, and that's it. And the core patent on this drug in India expires today, March 21st. 15 plus Indian companies are lined up for day one launch. Prices could come down 60 to 70%. A drug that costs 12,000 rupees a month today is coming down to almost 4,000 rupees for a pen and 1,200 rupees for a vial. Now think about this as an investor. Indian generics with a 5-year head start over the US and a million of patients waiting for an affordable option. And to help us really understand the clinical side of this, we have two experts with us. Dr. A.G. Unnikrishnan, CEO and Chief of Endocrinology at Chelaram Diabetes Institute, Pune, and Dr. Shalu, founder and MD of Kinforce Clinical Science out of Hyderabad. Sir, ma'am, happy to have you both and thank you for joining. Okay, so simple agenda today. I'll walk you through the investment thesis slide by slide and we'll hear from our experts and then we can open it for our questions. First of all, what is GLP-1? So for those who are new to this, I keep it very short. GLP-1 is a hormone your body naturally makes. It controls blood sugar, controls appetite. Pharma companies have made a synthetic version of it. You take one injection once a week, as we already discussed, and it works for 7 days. That's the product. It started as a diabetes drug, and almost by accident, patients started losing weight. Then cardiovascular benefits showed up, and then other kidney and liver benefits showed up. So you have one molecule that treats multiple conditions, and that's why the market is so big. Now the investment question is, who makes the money from this? Right now, only two companies dominate globally, Novo Nordisk and Eli Lilly. If you see how big is this market is, next slide again. Semaglutide alone did 26 billion in global sales 2024, growing 40% year on year. And this is one of the fastest growing drug categories in the history of pharma. But the real question for us as investors is, where do the patents expire? Because that's when the Indian opportunity opens up. You can see the US is locked in till 2032. Europe protected to 2031. Novo is fighting hard, 26 injections filed. Canada is already open and patents lapped because Novo didn't pay the fee. You can see that Brazil is opening in this quarter 2026 and Dr. Reddy announced day one launch. And India, 15 plus companies ready to go today. Now you look at this map, 4 columns, 2026, the year of the generic, India, Brazil, China, Canada, Turkey, South Africa, Mexico, all opening up this year. 2027 to 2029, the emerging market wave hits. The GCC countries, Latin America, and South Korea opens up. 2031, Europe finally opens. And the US, last to open. 2032 at the earliest, with a secondary patent stretching up to 2038. Now, patent expiry, price collapse, and volume explosion. Now, those of you who have already invested in Indian pharma before, you know this playbook. The patent expires, generics come in, price crashes, and the market actually gets bigger because suddenly more people can afford the drug. And today, about 2 lakh patients in India are on GLP-1. Monthly cost is 10 to 12,000 rupees. And after the patents expire, it will come down to 4,000 and almost 30 million patients can afford it. It will become in the market size of 9,000 crores. In the coming slides, I will let you know where I got that 30 million number. Now, the question is just where the chain do you want to be positioned? The value chain. And the most critical question for investors, who will win the value chain? I want everyone to pay attention here because this is where the investment decision actually lives. Think of it as three players, originators, Novo and Eli Lilly. They created the drugs, they enjoyed the patent, but now the prices have already been cut. Novo is down by 37%, and the partnership or distribution is given to Emcure and Abbott. In the reality, the peak dominance is behind them. Second player will be the generic players. These guys will fight for the price war. The competition is intense. The margins are under pressure. Only those with strong diabetes presence will survive, like Lupin and Eris, not Natco, who have less presence in diabetes. And third, the enablers. Here, the players are limited and the margin erosion is very less. Whoever sells to generic suppliers will be common across. And hence, we think the biggest beneficiary in this space will be enablers, the highest chance of winning. Companies like OneSource, Plant Pharma, Enzyme, Biocon, Shelly Engineering, these guys make API, they do all fill finish, and they make the injection pens. And here's the thing, they sell to everyone, originators and generics. Now, if we see the India opportunity, let me give you three reasons why India is actually the biggest opportunity globally. We saw the 30 million number before. You can see that 101 million are diagnosed diabetics in India and 136 million are pre-diabetics in India. That's we get the 30 million number from. And the three reasons why India is actually the bigger opportunity here is first, the phenotype means that India has what doctors call the thin fat phenotype. Basically, Indians develop diabetes at a much lower body weight than the Western patients. You don't need to look obese to be diabetic here. So the eligible patient pool in India is actually wider and not narrower. Second will be the guidelines. RSSDI, India's top diabetes body, added the GLP-1 drugs to the official treatment guidelines in 2023. And third will be the affordability. The only thing that holding back was the price. So if you see, India is not a small market for GLP-1. By patient volume, it is the largest GLP-1 in the market in the world once the affordability improves. Now, if you see the healthcare, where the India's next big creation theme, and before I call the experts, how BVCA sees this as an opportunity. We believe the next investment opportunity is healthcare because the healthcare market is $178 billion today, projected to reach 1.5 trillion, and that's 18 to 20% annual growth. And who makes the generics for the world? India. 20% of global supplies and 40% of US generics. And not just pharma. Think about infrastructure. India has 15 hospital beds per 10,000 people, and the global average is 29. We are literally at half. As this population ages, as health insurance spreads, as incomes goes up, demand for beds, devices, and CDMOs all compounds. And that is why we have recently launched the DVCA Healthcare Compounder Small Case, a curated portfolio across the entire healthcare value chain, and each stock handpicked by a research team. The thinking is straightforward. And if this interests you, happy to share more after the session. And with that, I would love to hand it over to Mr. Dr. Unnikrishnan to have a few words on this, and then we can go to the question answers. Thank you so much. Dr. Unnikrishnan, we can.
Greetings. I hope I am visible and audible.
Yeah, yes, you're audible and you're visible. Yeah.
Thank you. So, thank you for inviting me to this meeting. I must first of all clarify that I'm here as a doctor, a clinician, and a researcher, and obviously Whatever I say is not to be taken as any investment advice or even financial educational advice, because I am a medical doctor here, trying to give you a clinical perspective of the GLP-1 landscape and what the future holds for us. I work at the Chalaram Hospital in Pune, and we are a hospital dedicated to diabetes care, uh, uh, care of diabetes and all its complications, and also associated conditions like obesity. Next slide, please. So I'll be talking about what the future holds for us from a very clinical perspective. May I have the next slide? So let's look at what is GLP-1. So GLP-1 is called glucagon-like peptide. Now, supposing you're going to have your lunch, and let's assume that you're going to have some rice for lunch. That rice has to be broken down into glucose, and the glucose works on your cells in the gut, and the gut produces this hormone called GLP-1, and GLP-1 is will release insulin, and the glucose which was there in the rice and now reaches the blood will be brought down by the insulin which is released thanks to the GLP-1. So when you eat rice or bread or roti or anything sugar, what will happen is that sugar will stimulate your cells in the gut. They'll make GLP-1. GLP-1 will tell the pancreas gland to release insulin when the sugar is high. And once insulin is released, the glucose in the blood is used up by the cells and the glucose level comes down. So that's the first action of GLP-1. But it also turns out that GLP-1 has an action beyond glucose control. Initially, GLP-1 related drugs were used for diabetes, but then they found that these drugs were causing weight loss because they tell the brain to stop eating. So that's another effect of GLP-1. People have also looked at GLP-1, which to bring down the glucose levels, it also talks to the liver. And in type 2 diabetes, the GLP-1 signal is either weak or blunted, and GLP-1 drugs restore it. So GLP-1 is like an intelligent software for the pancreas. When the sugar is high, it releases insulin to control the glucose levels. But the important thing to remember is that it also acts on the brain to suppress appetite, and that's the main reason for their weight loss and use in obesity. Next slide, please. So this is the way it works. As I mentioned, it acts on the pancreas for sugar control. It acts on the brain. Some people call it the hunger hormone. It stops hunger, and it acts on the brain and reduces hunger. The third action is more interesting because via its effects on glucose, via its effect on suppressing appetite, via its effect on weight loss, studies have now shown that it can have a protective effect on the heart. It can cut down the risk of heart attacks and strokes in people with high risk diabetes, and also newer studies show that it can also similarly cut down the risk of cardiovascular events even in people without diabetes who have obesity. Next slide. So that talks, now we talk about the effect on diabetes, because initially these drugs were discovered as anti-diabetes drugs. The GLP-1 drugs are not new. They have been here for almost 2 decades now, 15, 18 years. But what is new is the newer forms of GLP-1s, which have got a strong effect on weight loss, such as semaglutide and tirzepatide. So how does this drug stack up against the existing drugs? I'm not talking about diet and exercise, but I believe diet and exercise is fundamental. But what you will see in this column is on your left, you will see all the drugs. Second, from the left, you will see the glucose reduction, the HbA1c reduction. Now, the HbA1c is a simple blood test that tells you the 3-month average glucose levels. In people with diabetes, generally, we keep it below 7%, but below 6.5% is ideal. You will see that among all the drugs, insulin is a drug with the major HbA1c reduction. But insulin has two problems. Insulin causes weight gain. Second, too much of insulin can push the blood glucose levels below normal. And that is why the GLP-1 agonist and the GLP-1 GIP that works against two hormones, these drugs also have very good A1C lowering. They do not produce weight gain. In fact, they cause weight loss, and they don't produce very low blood glucose levels below normal, hypoglycemia, which can be dangerous. So this is the advantage these drugs have over insulin. And on your extreme right, you'll see the cardiovascular benefit. Sorry, go back. On your extreme right, you'll see the cardiovascular benefit, and you'll see that both the GLP-1 RA, that is semaglutide injectable, and the GLP-GIP, which is tirzepatide, both have probable cardiovascular benefits, which are more or less accepted worldwide. Next slide. So now let's look at injectable versus oral. Oral semaglutide has been available for many years now. So on your left, you'll see the injectable, and then on your right, you'll see the oral. You'll immediately see that injectable causes better A1C reduction of up to 2.5%, and the oral causes less A1C reduction of 1.4%. You'll also see that the weight comes down by 10 to 22% in injectable and 4 to 8% by oral. There's a small mistake in the oral GLP-1 slide. The oral GLP-1 is semaglutide. Oral liraglutide and oral tirzepatide are not available. Instead, a drug called orforglipron is going to come. So oral liraglutide and oral tirzepatide are just hypothetical and they're not really available. So now I want to talk about the problems with injectable. The only problem with injectable is the injection barrier, the cold chain. It has to be transported at a particular temperature, and a high cost. The oral one, the limitation is a limited bioavailability. Whatever is eaten is not absorbed properly. Also, the oral drug, the oral semaglutide, has to be taken on empty stomach with half a glass of water, half an hour before the first sip of tea. So it's very rigid dosing, and therefore it is somewhat less effective than the injectable. But there is a molecule from Eli Lilly called orforglipron, and that probably may not have such limitations. Next slide, please. So that brings us to the Indian patient and Indian diabetes crisis. So as mentioned, there are 101 million people with diabetes in India, 136 million with pre-diabetes, 50% are undiagnosed, and among those who are diagnosed, 50% are uncontrolled. Right now, the GLP-1 monthly costs are very, very high, and affordability is a primary barrier. The liraglutide, which is injected daily, is available at about 3,500, and the weekly injectables are available starting from 8,800, and depending on the molecule can go up to over 20,000 rupees a month. So it's very expensive. And many Indians are, as mentioned earlier, are thin but have abdominal obesity, which drives diabetes. Abdominal obesity makes the body resistant to insulin and drives diabetes. The urban middle class segment is a good proportion of people are not able to afford it now and will afford it. And we hope that generics will come into the Indian market, and that will improve the accessibility to care and also bring down the cost. So the penetration across India will be there, and the cost also will come down. That will be very good for patients. Next slide. May I have the next slide? Okay, now we look at the obesity landscape. There are around 254 million people with obesity in India. 44% are overweight also. And of course, 5% have diabetes. Five-fold higher diabetes risk is there in obese people. When compared to people who are not obese, people with obesity have 5 times higher risk of diabetes. Obesity is now, earlier, obesity was not considered to be a disease. People were thought to be healthy. But today, the WHO itself has classified obesity as a chronic, which means it's a long-term disease. It's also a relapsing disease. If diet and exercise control it, it bounces back. So obesity is a condition characterized by excess weight that impairs health and, if not treated, can lead to complications such as type 2 diabetes, which is a common form of diabetes, hypertension, sleep apnea, NAFLD. The new name for NAFLD is MASLD, uh, which was earlier called fatty liver disease, arthritis. So many diseases are associated with obesity, and only 3% of obese people worldwide get pharmacological therapy. There was diet and exercise, then there was bariatric surgery. There was nothing in between for us to tell patients. Now, since 1 year, we have injection tirzepatide uh, and injection semaglutide. Next slide, please. So, what does the next 5 years foretell? So we saw in 2025, we saw that Eli Lilly launched Monjaro, which is tirzepatide, and Novo Nordisk launched Wegovy or Ozempic, which is semaglutide. Wegovy and Ozempic are two brand names of semaglutide. Wegovy is for weight management because the dose goes up to 2.4. Ozempic is for type 2 diabetes management. In general, the dose goes up to 1, but in the US, even up to 2 mg is approved for treating type 2 diabetes. So obese people with a body mass index which is high uh, can receive treatment with these drugs if they're not responded to diet exercise. Well, in 2026, as we speak today, we have the Indian generic semaglutide injections, which are weekly injections coming. In 2027, we expect that newer molecules will come, single molecules which will target multiple receptors. In 2028, we may get another oral pill, and these studies are being also, these molecules are being studied for NASH, which is earlier called fatty liver disease. A new name for NASH is MASH, metabolic dysfunction associated steatohepatitis, sleep apnea. Uh, there are interesting studies, important studies looking at the effect of these drugs on dementia because they act on the brain to suppress appetite, and some interesting data is there that they may improve dementia, but it's not approved and we don't have trials yet which are positive. And finally, in 2030, we may get data on GLP1 for addiction, for kidney disease and heart failure. There is already a kidney disease trial available for injection semaglutide in type 2 diabetes called the FLOW trial, where it protected the kidney. Now, these drugs suppress appetite, and by suppressing appetite, they take away the joy of eating. Similarly, like reducing food craving, they reduce the craving for alcohol, they reduce the craving for smoking. So they have been tested in addictive disorders, and many such cases are being reported by doctors. I want to add that these drugs are not without side effects. They have good effects, but they have lots of side effects. They can not just cause good sugar control and weight loss, but they also cause a lot of gastrointestinal side effects, especially at the time of starting the dose and increasing the dose each time, because you have to keep on increasing the dose till the target weight loss and or sugar benefit or whatever is achieved. They are also they have they are contraindicated. They should not be used. Contraindicated is a more medical term. So it should not be used in people with severe depression, especially with suicidal ideation. The suicidal ideation tag was supposedly removed by the US FDA, but the depression tag continues to be there, and we should not use it. Doctors should not use it in severe depression. People with a family history or with a history of a rare thyroid cancer called medullary thyroid cancer should not take it. These also carry a risk of pancreatitis because they stimulate the pancreas gland, which makes insulin. They also may cause some damage to the pancreas called pancreatitis. They also very recently and over the last year, they have been shown to cause a very rare condition of the eye uh, where it can affect vision. And also, in people with diabetes, they can worsen diabetes-related eye retinal disease. Retina is a screen behind your eye with which you see the world, including this screen in front of you is seen by the screen on your eye. And that retina is directly can be affected by these drugs if sugar control is very rapid. And this retina can be directly seen by the ophthalmologist. In fact, every diabetes patient should have a retinal checkup annually, even otherwise. And this If it's very severe, we should not use this drug. And finally, these drugs can weight loss doesn't mean everything, because weight loss can be fat loss and fat-free mass loss. What is fat-free mass? Fat-free mass means muscles, bones. So for every 4 kilos of fat loss or weight loss, 1 kilo may be lean body mass or muscle. So they can cause muscle loss, which means people may become frail. So people may have to do strength training and improve protein intake. I thought it's important to give a perspective that these drugs have to be used judiciously under medical supervision, because they have effects and good effects and lots of side effects, and should be taken under medical supervision. Uh, Next slide, please. But it's all very exciting because GLP-1 is a very powerful drug. It acts on the sugar, weight, and heart. India is the world's diabetes capital, and we could not do much about weight other than diet, exercise, and bariatric surgery. But now we have another tool to help patients. And the affordability generics will really help improve access and cost. Diabetes is a chronic condition, so good uh, uh, brands could emerge which will help patients. Obesity was not really treated, but now GLP-1 will change that. And beyond diabetes and obesity, it may have a protective effect on the heart, the liver, on addiction. And therefore, people are saying that it could be a big boon. But at the same time, I would be a little cautious, because yes, there is some chance at helping a lot of patients, but also there is a chance of misuse and side effects. And therefore, we will have to be we will have to wait and watch how the GLP-1 story proceeds. Thank you. Next slide, please. Thank you for listening to me. It's a pleasure talking to you. And the organizers told me that I can take questions straight after my talk. So I'm happy to take any questions right now.
Thank you so much, Doctor. It was a wonderful, detailed explanation. And I will let other people ask some questions on this. I will let first Nikhil ask a question. He wants to ask some questions. Allow your mic, Mr. Nikhil.
Hi, am I audible?
Also,
Yes.
before
Yeah,
Nikhil, if you go, I just wanted to keep the questions brief because doctor may
yeah,
be
yeah,
running out
sure,
of time.
definitely.
Yeah.
Yeah, thank you, Dr. Unnikrishnan, for this detailed insights that you shared on a weekend. Sir, I had just one question. We discussed about this GLP, where we have seen a lot of generic companies now come up. Natco yesterday launched probably vials at some 1,300 rupees. So I just wanted to understand how will in your clinical experience, what is the dosage accuracy difference that you see between a pen-based dosage versus a vial-based dosage? And do you think that vials can probably take over the semaglutide prescriptions vis-a-vis the pen? Like, just trying to get a perspective. What do you
Thank
think
you.
of? Yeah,
Well, if just to give you an example, initially when tirzepatide, which is Monjaro, was launched in India, Eli Lilly launched it with vials. And then the uptake by July first week, they launched pens. So first March, April, May, June, they were vials. And what we found is that vials were acceptable to patients just like pens, because at that time there was no competition. But today, with a large number of different devices coming, I think vials will be only for people who have an affordability issue. Because from what I hear, the price is really going to come down. So vials will be only for people with an affordability issue. Most people would like to take pens. There may be single dose pens, there may be multi dose pens, but pens are more convenient because it's easy to carry around when they're traveling, or if they've forgotten to take it, they're able to take it out, put it in the fridge, take it out, take it in a syringe. So I think whilst pens will be the vast majority of patients, but vials will really improve access to the really poor who need it.
yeah, this is helpful. So thank you so much. I'll come back in the queue.
Yeah. Prashant is asking that does this injection need any regular blood tests or monitoring?
Yes. So, for example, in our institution, we have a pre-GLP-1 assessment testing. People come in fasting for the test. They do their height, weight, their blood glucose levels, their cholesterol, their blood pressure, their ECG, but they also do two, three additional tests. The first test they do is, of course, their kidney function. But the first additional test they do is we insist on an eye checkup because it's important to do an eye test before starting this because if there are some risk factors for eye disease that gets picked up. The second thing we do is we do their body composition because sometimes when people rapidly lose weight, they may lose muscle and that may make them frail. So we do their body composition. So these two tests are done. And we also, whenever we start the GLP-1, our team trains them. And also, we also insist on many people who say they have to do strength training and increase protein intake. So they meet a dietitian and the strength training, resistance training. For that, we arrange a small demonstration at their lifestyle at our lifestyle center because people ask, डॉक्टर मसल लॉस प्रिवेंट करने के लिए क्या कर सकते हैं? तो I usually tell them that you can do two things. You can do strength training and protein intake. Now, strength training is more important than protein intake because that strength training will prevent. So these things have to be done, and that's when you get the maximum benefit.
Yeah, super. Also, RK is asking that are vials and pens interchangeable? Like, can vial patient use pens for sometimes, like if they go on a trip?
Absolutely. So
Yeah.
what happens is very interestingly, these drugs cause gastrointestinal side effects. So some of my patients who are working, say in the IT sector, they will take it on a Friday and then they will take it because they get the gastrointestinal side effect on Saturday, Sunday, Monday they can go to work. But people who are say going from Pune to say Goa, for example, they will take it on a Monday because they don't want to get the gastrointestinal side effect during their holiday. And so they usually take the via pens with them when they travel and vials at other times. But today we don't have vials because Eli Lilly only launched vials for the first few months and now it's all pens. I suspect pens will be the main way doctors use it because uh, pens are also affordable today to the majority of people and people uh, who need these injections also need regular monitoring so that pen will be the main group who can afford both the care and the monitoring and everything else.
Yeah, perfect. Now, also, Prashant is asking one more question. Do patients need to take these medicines lifelong or can be, discontinued after a certain clinical goal is achieved?
So across the world, studies have shown that people don't take this GLP-1 long. People who take it for obesity tend to stop it after 6 months, 1 year, and that's a huge challenge for clinical doctors. So studies have shown, now if you want to know the science, studies have shown that if you give it, there's a SURMOUNT-4 trial done on tirzepatide, and there is another trial for semaglutide. What they did in these trials is they gave these drugs for say a year or 1.5 years. Then after they took it for a period of time, they stopped it in one group and other group continued to take it. The group which stopped it after 1 year, let's say they lost about 15 to 20% of the weight. Once they stopped it, within 6 months to 1 year, half the weight jumped back. In other words, if they stop the drug, on an average, half the weight will come back in a year's time. But many people are able to manage with diet and exercise. But people who take it for diabetes are unlikely to stop it. The reason is because there is a very tangible health outcome on the blood glucose level. And if they stop it, the weight comes back, the sugar comes back. But for weight, the people who take it world over, they have shown that people tend to stop it. And I think that's not correct because when you start it, you should start it for a long period of time. And if you stop it, patients should follow diet, exercise, and if the weight comes back, they may need to start it. And that's been a challenge with GLP-1. You've identified that problem with many people stopping it, and there's an opportunity for some education and awareness of the public there.
So it's not just the drug. We need to combine it with the exercise and diet as well. Perfect.
Absolutely. It is not diet exercise versus these injections. It is diet exercise plus these injections.
Understood. Perfect. Ashish wants to ask some question. If allowed your mic, Mr. Ashish, you can ask the question. Mr. Ashish? Uh, okay, I think so he's muted. There's a question from Mr. Uday. He's saying that was there a second order effect of GLP-1 on Indian, let's say after 10 years, if an Indian patient loses 10 kg on these drugs, but 4 kg of that is muscle, aren't we just making them thin but weak? Specifically, when they stop the drug and inevitably regain the weight, don't they regain it at 100% fat, leaving their metabolism permanently broken and worse off when they started?
Yes, you are absolutely right. Because once, if the patient taking this drug is not monitored, and if this patient loses a lot of muscle, this patient may lose weight, but they will look very thin and frail, and they may be prone to falls as well. So we are not helping that patient really. And very interestingly, once the weight is gained back, there is no guarantee that you're going to gain back muscle. Once you stop it, you may gain back more fat. And whatever muscle you've lost, if the patient is not exercising, they don't gain it. So if you see the new generation of drugs that is going to come next, is combining this GLP-1 with agents that improve muscle development so that you can get fat selective weight loss. There is one particular molecule called bimagrumab, bimagrumab, which is when combined with GLP-1, GLP-1 will cause fat loss and bimagrumab will prevent the muscle loss. But for the moment, there is no such agent. So we'll have to tell the patient to follow strength training and also increase protein intake because we want our patients to get better health, not simply lose weight. And also, people taking it just to lose weight for cosmetic purpose has to be discouraged strongly because this is a medicine for health, not for just weight loss.
Perfect. Ashish can go next. If I allowed your mic, Mr. Ashish. Like he's asking from a long time. I guess his mic is not working properly. Uh, okay, Aditya is asking that given we don't have any long-term data on GLP-1 behavior in Indian population, both in terms of efficacy and side effects, how are doctors building confidence to prescribe them in the long term? There's no studies for the long term.
Well, I think any molecule that comes into the country or into the world usually has an initial very strong phase where doctors are very, very excited by their use. They see weight losing, patients are excited, everybody is happy. Then will come a sort of realization that yes, this drug has to be used selectively. It has got some side effects. Many people will lose muscle. And then there'll be a consolidation phase where this drug will be taken up. So I believe that yes, initially you will see some euphoria around this molecule, but eventually, the medical practice will go to the right patients and will help. And from day one, doctors will only use it for the right patient. But the people who are looking for weight loss will discontinue it on their own. Doctors are going to use it for the right patient, but patients may discontinue it. So this is the story. Initially, many people will come asking for it. Their BMI will be 35, 40, very obese. Doctors will write it because they need it, the patients need it, but then people may stop it, and then that's not a good thing. So I think in the long run, it will all be the long-term use of these drugs giving benefit to patients, so that initial increase in numbers may really come down over a period of time to some stable numbers. But I feel that this will continue to be used for years to come.
Perfect. I think so. We can take a last question from Nikhil today, and because sir has some other meeting to go after this. So, Nikhil, you can ask your last question. Keep it brief.
Yeah,
Yeah.
yeah, yeah. Just a
Thank you.
follow-up, sir. Probably the pharma companies who have filed the dossiers with pen, if they want to switch it to vial, will they need a fresh regulatory submission? Maybe a very naive question, but if you have an idea on that, that would be really
No,
helpful.
I don't have any idea on that. What is the regulatory? So apologies, that's one area I will
No
not be
worries,
able
no
to
worries.
help you.
Thank you so
Thank
much.
you,
No
thank you,
worries.
thank you so much, Doctor, for coming today. Explaining all the slides in very detail and asking, answering all the questions, very beautifully. Thank you so much. We can, invite Doctor Mr. Shalu and thank you, Mr. Unikrishnan. We'll have to.
Thank you,
Thank
Dr.
you.
Unni Krishnan sir. Amazing. Thank you so much. It was an amazing presentation, and I think Q&A was also great. The kind of insights you gave us were really great. Thank you, sir.
Yeah,
Thank you
yeah,
very much, and
definitely,
thank you for having me here. Bye.
definitely. Thank you so much, Doctor. Yeah, we can invite Mr. Doctor Shalu here. She also have to give some insights on GLP-1, and then we can ask her questions. We can start her presentation now. in few minutes.
Yeah, hi everyone.
Yeah, hi, Dr. Sir. We can hear you
Yeah,
can hear
you
you.
can hear me well. You can see as well,
Yes,
right?
yes,
Okay.
yes, perfect.
Okay, I think we can start from the slide itself because the time is little less and a lot of things I wanted to convey, but we have to take care of time constraint. So, hi everyone. Thanks for joining the session. And I would like to thank Divishi to give this opportunity to me, myself, Dr. Shalu Kasliwal, who is the founder and managing director of Clinical Clinical Science. The company is involved in various pharma activities, and we do like a lot of regulatory expert work as well as a lot of medical monitoring work, and quite actively doing medical affair work as well, like which include sales and marketing kind of work. So today, as we are discussing GLP-1 landscape, I would like to present few slides on how this drugs have got approval across the globe as well as India, and then maybe peptide and biosimilar. A lot of queries are coming, like what are the difference between peptide and biosimilar, and then like upcoming Indian landscape and pipeline. As we all know, like today, GLP, like semaglutide is getting already got a patent expiry, and a lot of drugs are lined up to launch their product. And in our pharma world, like a lot of excitement is going on towards that, like who will win, who is doing what, and a lot of discussion around it. So I would like to give brief of it in my slides, and then maybe what kind of different approaches they are doing to get more effective, in market, to sustain in the market in tough competition and all those things. So this is like an upcoming generic wave in India, and we are looking forward for it. So thanks once again, Dr. Krishnan, to give overview of disease itself and disease burden as well as the mechanism of action of various drugs and the disease nature of disease. So we can proceed for further slides. Yeah. So before we speak in detail about regulatory and other this thing, so this information which I've captured in my slides are mainly taken from available public, forum, and like publicly available sources. And these slides are only for educational purposes, not for any clinical or any promotional use for these drugs. So I would like to make this disclaimer before we go into the detail. We can go to the next. So here you can see, like I have captured the detail of GLP-1 class approval across the globe. So these countries, mainly US and Ashish, are we on wrong slide?
1 second. Yeah, is this correct, ma'am?
Yeah, okay.
1 second.
I think there is some error.
One second, I will present it again. Sorry, everyone. I will just present it again. Right.
Dr. Shalu, can you present from your screen? That would be better. I think there's some glitch.
Okay, okay. Let me try and see, like, if I can do for my slide.
Thank you.
Perfect. Yeah, we can see your slide. Yeah, perfect.
Okay, that's nice. So I wanted to give overview on various approvals which these drugs has got across the globe, including US FDA and Canada and Brazil, and followed by UK, Europe, India. So various countries has got approval for various class of drugs. And we can see, like, this approval started in 2005, long back in 2005 for diabetes indication. You can see type 2 diabetes indication was I will just try and see, like, if I can do much. Yeah. So you can see the pointer, right?
Yes,
Yeah.
we can see.
So so this drug, first drug is exenatide, approved in 2005, long back, for type 2 diabetes in a pen format, and that got patent expiry in 2012 as per laws existing during that time by FDA. And this had frequency, like the pen frequency was daily dosing, and then later on this other drugs came in pipeline, like liraglutide, exenatide, extended release, which is having weekly frequency and other things, and like liraglutide for obesity also increased, which is having higher dose and more frequency. And then the major break came through semaglutide SC injection in type 2 diabetes by Novo Nordisk. And this drug has weekly frequency for the injection, as well as the lesser side effect. As Dr. Unikrishnan already mentioned, a lot of GI side effects were associated with these kind of drugs because they are directly acting on GI tract, and less frequency of nausea and vomiting were seen. And this later on, the obesity indication was also approved by FDA in a form of pen, which is called Wegovy. The brand name was Wegovy. And then Monjaro, we all know, like tirzepatide has come by Eli Lilly, and for type 2 diabetes mellitus, but it has being used in obesity also very, immensely across the globe. And oral Wegovy 25 milligram was approved by FDA in last 2025. So over the period 2005 to 2025, the drug has seen the various molecules, has seen various kind of indication. Now, I came to know yesterday only, like, this Wegovy HD is also approved by FDA. On 19th March, it was accelerated approval by FDA, and it is mainly for obesity. For longer term, I would say long-term obesity effect, as we know that it's a reversible effect coming, like once you stop the drug, and immediately the patient start gaining the weight. This indication, as of now, say I have to go more detail on it, but as of now, this details are written as long-term obesity, cure. The Canada is having interesting story. Like the Novo Nordisk has launched their drug Ozempic in 2018, but this they have not. I think in first slide by Divishi, this is already mentioned. They have not given the annual fee to keep their patent, and then the patent got released this year only, and this market is freely open for other generic companies to come and give this approval by Canada if their data is in that line, like which is required by Canada Healthcare. The Brazil is
Perfect.
another
Got it.
market.
Yeah.
Yeah,
Yeah, we can go.
you're saying something? Okay.
No, no, no.
Yeah. And like in Brazil, like, which is again a bigger market, the August 2018 this journey has started, and 2024 was the last approval for by Monjaro, and the score patent will get released very soon. So various drugs, various other generic pharma companies are also planning to go into those markets, and this Q1 2026 is open for this Brazil market also. And when you go for any new drug, new generic, it takes a lot of time to undergo the trial and but with generic, the journey is little smaller. You know the side effects, you can do the improvement. So there are various benefit going as a generic and first to file kind of companies, and we can see with these kind of picture coming out of these slides. So yeah, so I would like to present here in EMA, like, where this approval has started little late, but due to a lot of separate patent, supplementary patent certification, this is going till 2031 for semaglutide, and then this will take time, means to open for the generic market. So I'm focusing mainly to generic market, which can launch their product into these markets. But for India, yes, as I mentioned, it's a very big day today because the patent got expired, and a lot of generics are there in pipeline to launch their product today. So over the period, like when we can see the 2020, when this journey started with India, GLP-1, the first company, Novo Nordisk, the innovator, they came with their drug called Rybelsus, which is oral drug, like very widely used across the country, and that's the only semaglutide was available till this time. But now this patent expiry, a lot of other companies like Sun Pharma, Zydus, Alkem, MSN Lab, Netco, Torrent, many companies are coming. They have submitted their data for various indications. We can see like type 2 diabetes, obesity, CKD, the chronic kidney disease, cardiovascular indications. So various indications they have, filed their applications and got the approval based on the data provided by them. So so they launched, maybe we'll hear by newspaper or news channels or the educational forum like this, that which company is coming and launching their product at what time. So multiple generics are ready, and this is going to be a major competitive market for India. We can also see like CDSCO approval has evolved. Innovators used global data. Generic now require India phase 3 shift. So initially, like when this Eli Lilly came for this first type 2 diabetes indication, GLP class 1 I'm talking about. So they've done with the standard NDA approval process. Later on, the liraglutide and other drugs like which has come into the Indian market, they have gone for their clinical trial data and phase 3 data they have produced to the India. Different kind of trial data called sustained trial data. I'm not going into detail of these trials, but the trial itself known as sustained trial data, pioneer trial data, they have gone to DCGI and given their bioavailability approvals. Then like later, the company called Biocon, they came to the market and they applied for Route 101, where US, Europe, UK approved reference data was used for to get the Indian approval. But when this other companies came and produced their data in different indication like obesity and type 2 diabetes, so they have given with the difference. The trial was done in such a way that it was quite convincing for the CDSCO that yes, you have to do phase 1 and phase 3 trial in Indian population. If any kind of waiver or any kind of bridging study is needed, they will give upfront suggestion to them. But looking at the market and looking at the excitement in the market, they made it very clear, like you have to undergo with proper trial, and you have to submit all those trial to get the approval. So we can see like CDSCO has given various list of trial which is needed. Then waiver and everything depends on what kind of data the company has produced. So phase 1 trial data in India, they're asking for Indian subjects to be exposed to PK study. If it is not done in this thing, it can be waived based on NDCT rule, but that depending on what kind of data you have done outside India, and then what kind of this suggestion you are coming to India and getting this approval. Phase 3 trial, like Indian cohort in global trial, 10 to 30%, or standalone Indian trial also they are recommending based on indication, based on their application. Various bridging studies for any new indication. If you are going, let's say drug is approved in diabetes, but you want to go for obesity, or if there is any change in indication or something like that, then based on their application, they are giving a suggestion for bridging studies. Cardiovascular long-term safety effect, they have made it quite they are supervising quite well about the side effects and other things. During the trials, we have it has been noticed that other side effect, like Dr. Krishnan already mentioned about these, like retinal side effect and other things. So they are recommending, making recommendation based on available data and based on side effects seen, and they are giving queries as well as follow-up studies for post-marketing data on these side effects. Now, like it is mandatory to do post-marketing surveillance data for 2 to 4 years, and give submission of these side effects, like as a pharmacovigilance activities. As we can see, like it's getting exposed a wider. The cost is reducing. Obesity is very much prevalent in India, and when so many market players are coming, it's expected that more people will use these drugs, and we will see more side effects as well, like in more number of side effects. And so we have to keep a close watch on side effects which is coming in a broader population. And those kind of things will come through PSUR, PBRR, which are typically pharmacovigilance activities, which these companies has to submit to DCGI. And based on data is coming, DCGI may make further recommendation, safety recommendation, I mean to say, for these particular drug. There are a couple of companies where immunogenicity testing also they have recommended. The kind of data they have produced. Then some companies went to DCGI with European standard BMI, where Dr. Unikrishnan just mentioned, like the BMI which is being BMI standard which is being used by other countries like Europe and US. Indian population is little leaner into that aspect when they comes under obesity category. So this like when we prepare a clinical trial protocol, we keep a criteria called BMI, and DCGI has given recommendation, like you have to include people with lesser BMI, like which is falling under the definition of obesity for these particular trials, instead of going directly to the higher kind of population. So that will definitely, these kind of recommendation will definitely give a lot of brainstorming when you do these studies, for especially for India, country like India, where huge population is exposed to diabetes as well as obesity. So Indian demographic data, that again you have to consider while designing a trial and getting the approval. And then like local GMP compliances, we have to where the manufacturing is being done, what kind of the guidances they have, what kind of certification licenses these facilities are having. So all these things are under consideration with DCGI. So like again, ethicals, we will not go into this detail, but yes, in short I can say that DCGI had made NDCT rule very clear, and SEC approval requires PK and phase 3 data. And further to this, we have to take care of for safety of the Indian population. Now this slide is a little very in short, I wanted to say, like, what is peptide and what is biosimilar. So initial confusion was like, why these drugs cannot be considered as a biosimilar, why this is being considered as peptide. Now we can see this from this table, it is very clearly visible, like what kind of differences these semaglutide generics as well as the biosimilar, where the insulin and other liraglutide biosimilar was there, what kind of differences it has. So semaglutide is purely synthetic like molecule, we can say, not as a biosimilar which is being produced by living cells. So these are their manufacturing, semaglutide manufacturing is typically called solid phase peptide synthesis, and where the molecular weight of semaglutide is much lesser than biosimilars. And then the manufacturing route itself is a peptide synthesis. Every company is having their own mechanism of this synthesis, but the companies which has got DCJ approval, they have produced their data in front of them, and they have, once they're fine with that data, they have given the approval to launch the drug today. Now, like characterization is a little easier in small molecule, I will not say small molecule, I will say synthetic peptide than biosimilar. Biosimilar characterization very complicated, and a lot of batch to batch variability is visible. But in this case, it is comparatively easy. Like trial, okay, for biosimilar, we have to have a specific regulatory pathway to be followed. Post-marketing study is very much mandatory in biosimilar since long time for Indian approval. But in this, as I said, like recently we are evolving, and then phase 1, phase 3, BE study requirement has changed over the period. And currently, everyone has to do phase 3 trial as well as the BE study also. Immunogenicity risk is there with peptide, but less than biosimilar. And interchangeability, someone asked this question. So if B phase 3 data is met with one drug to other drug, it can give approval of for the same molecule interchangeably. But with biosimilar, it is not possible to get approval despite of, means they have to produce a data to get the approval for interchangeability, designation. I think these are the main examples which has already, we all know, like, all generic semaglutide is coming in the market. And then with this kind of, the best part is peptides are low in cost, manufacturing cost is low, less number of data they have to produce. But with biosimilar, cost is little high and manufacturing cost is little high. It's coming from living cells. A lot of different challenges are there in manufacturing biosimilar. So some advantage with peptide, then what biosimilar molecule like liraglutide and insulin had challenges. So semaglutide may give some upper hand on these aspects. Now this is just an overview, like, when across globe the patent is getting expired. So India, 20th March 26 was the day, like, where this patent has expired. Canada, I already mentioned, like, when this patent is getting expired. Then skinny label strategy, like non-obesity indication, can be done in Europe depending on what kind of indication you are choosing. So the other indication, they are patent till 2031, and the US is last to open because their patent filing is little longer duration, and there are a lot of supplementary patent certification has been taken by companies. So in brief, like, the patent map 2026 shows, like, 2026 going to be a key year for the emerging market. Europe will open late, US much later, but India is already opportunity, Canada is also already opportunity, and Brazil can also be approached. This is again a history, like, how global as well as Indian DCJ approval came for the semaglutide specifically, not with other liraglutide, just an overview of semaglutide, injectable as well as oral. So 2017 we started with FDA, and then currently like Revlimid's 40 mg got approval for CV risk. So different indication has changed over the period, different kind of formulation, but the molecule is same, like semaglutide. So it has evolved, and I want to add 2026 for Wegovy HD for obesity also here in this table, which is missing. In India, we are lagging a little bit over in the year. Like 2017, they started with FDA, but yes, in India, molecule came little late in January 2022, and then over the period, it has got patent expiry. Now today, we have a lot of companies standing in queue to launch their product with a lot of excitement in the coming to the market. So they already got their DCJ approval. They already produced their data, what is needed to get the approval, and already resolved the number of queries what regulatory agencies might have made for their applications, and then they are available to go into the market. Now, this is like, apart from oral drug, interesting part of injectable is device. So many companies are doing different innovative experiments with the device also. Novo Nordisk was the innovator. They have produced their own device, and they have full package they have launched in the market. But the other companies, like the companies are doing either tie up with other companies to make, because it's expensive affair and lot of science, lot of research is needed, lot of technology is involved. So they are doing tie up with other companies, and then they are coming to the market. They are doing a lot of experiments with the devices, like reusable pen is coming, pre-filled pens are coming, auto injectors are coming, single use or multiple dose pens are coming. So different kind of pens are being launched by different companies, and auto injectors are having their own benefits, single use is having their own benefits, multiple use is having their own benefits. So various benefits as well as various kind of pens, like we can see in this right hand side of this table, like what kind of different pens are coming by different companies. Flexi pen, which was originally by Novo Nordisk. Then Zydus is already got approval by DCGI with multiple use pen. Sun Pharma is a pre-filled pen. And then Netco multi-dose pen. BD is having another science with pen. Many people are trying to have the pen similar to this thing, but we all know, like, this pen patent is patented till 2031, so no one can copy from original, like, innovator style of pen. So they all are having different ideas, different this thing. And interesting piece is, like, we'll see once the pens are in the market, like, which is more acceptable to patient, which is more convenient to patient for their use. And then maybe, clinician, where are they more confident, like, which kind of device is giving better compatibility to the patient use, and less training is needed, and other different kind of challenges they are facing with maybe different kind of design devices. So this is data, like, I've just taken from various available publicly available sources, and like nothing is taken from their own documents and other information. So be mindful, like, when you use a drug and the pen, like, what kind of things can make or break them. So we all know, like, generic is coming, and today semaglutide is a big day. What, like, the question is there across the industry, like, who will survive? So many companies has given so much investment, and they are long period data they have produced with various kind of formulation, oral as well as subcutaneous, with various kind of recommendations, and also who will survive better. That question is always there, and we it's a like hot topic today for us, like which company will do better in the market, which company will will have to produce something more to come into the market. So that kind of questions are already. So some key points I just kept here in this slide, like device differentiation. So some is using multiple use, some is using single use. So that we'll see, like, which kind of pen will get more popularity. Clinical data confidence. Somewhere someone has done the very vigorous phase 3 data and produced various safety and the safety and safety data, efficacy data, and different indications also. So that kind of, whether data confidence is giving them weightage, extra weightage, or the distribution strategy. Many companies are having good sales and marketing team with various good relationship with endocrinologists and physicians who are sitting in the market, and they give the confidence that yes, this drug is there. They are taking their feedback very positively, changing the things, like, the approaches which is needed. So if this kind of approach is giving more upper hand to in the market, that we have to see. Then oral semaglutide, oral, like, everyone is afraid of injection. I don't want to take injections, and I'm more comfortable taking oral drug instead of taking injections. So that kind of thing also we have to see. Like, the challenge with oral semaglutide is that get easily denatured in the gastric lining. Now, to prevent this denaturation process in gastric lining, there has to be a excipient called SNAC excipient, and currently very less companies are having that that unique the method to give that to prepare this oral semaglutide. It's not that easy, and not available as of now for with other companies. So maybe oral semaglutide is getting more popularity due to this technology availability. We have to see. And then beyond the pill ecosystem, now apart from writing prescribing drug, what other things can help to the patient? So it can be a health app, it can be a obesity guideline, it can be a healthcare nutritional guideline. These kind of things can give maybe upper hand to these companies, and depends, like, which company is coming with which kind of uh, uh, patient help system, where they can easily use it, and they can easily find it comfortable, and maybe using more this thing. So these are various points, like, which we have to see how the and the when which drug, which company is doing better in the market. I'm finding. So key takeaways, I already mentioned, like, FDA has built GNP class 1 system, like lot of indications, lot of new trials are being submitted, and then FDA remain, uh, data heavy in terms of indication and in terms of trials being done for FDA. India is already having very like large population of diabetes and as well as obesity. So with launch today, whether this access to generic will be easy. I have to change the price a little bit because this price has came yesterday and the slides were done before. So I think it's a little lower than this, which the price what generic companies has declared in their price list. So if the prices are so low, like they can get the drug so easily available. And then medical affair priorities, like which kind of launches you have to do, so that mindset and that approval you process you have to take care in front of CDSCO. And maybe with the demands is so much and then supply is less, then it will be a issue later. So we have to see, like we can have any accelerated approvals by DCGI. Today we have to produce phase 3 data, we have to do phase 1 trial, so that is taking time. And maybe the next lot of companies will take another 2 to 3 years to come to the market if they have not already started. So that kind of thing will be there. So, and I think we have to see the pipeline, like if any other companies are other drugs are getting prepared, which are much better than Munzara and also semaglutide. Also, we have to see, like if they are coming with better preparation, better uses, better devices, better technology. If they are coming with another innovative idea, so we have to keep an eye there. So this is going to be a very interesting journey and very innovative market for sure. And with this slide, I would like to end my presentation here. And again, this information is taken from publicly available sources, and I would stop here. Yeah, thank you.
Yeah, thank you so much. It was a very well articulated presentation, very detailed. Thank you so much for, having this conversation with us. I would like, if anybody was want to ask some questions to Dr. Chalu, they can ask the questions. Also, I have two, three questions lined up, but before that, if anybody wants to, ask some questions, they can raise their hand and ask the question. Dr. Shalu, there was a question from Nikhil. He was saying that the company with the pen had to launch vial. Do they have to take
Mhm.
any regulatory approvals?
They have to take approvals from the regulation, definitely, because approvals are coming based on the data you have produced, based on kind of application you have made. If it is you're changing any device, you have to go to DCGI. They may ask for bridging study, they may ask for separate study, they may ask other kind of data. And if it is already available, well and good, because when the companies are introducing new device, they generally produce some data. So they have to go with that data and take the approval. It is not.
Uh, but if the company already has the pen, the approval would be very easy, right, to go into a vial.
It depends, like what kind of claim, what kind of doses they are trying to, what kind of indication they are trying to have. It will be easy because the company will have basic data available at least with them. They need not to go into the chemistry and that level, the CMC data and that level. Maybe device
Perfect.
data will be more important. Yeah.
Perfect. I wanted to ask that, once this, generics, ideally available at 4,000 rupees a pen or, 1,200 rupees an aisle. So, what does how does the doctor's prescribing behavior actually change by because this affordability?
See, affordability is increasing. Obviously, more prescription will come. It will reach to mediocre household rate where the affordability is not much. In India, we do take care of our drugs and everything. Like the cost is a big factor for and rather in few states, I would say Rajasthan and all those things, where it is mandated by government itself. Like you have to write only generics, not like no innovator. There are a lot of rules behind it, but at top level, these kind of rules are there. So if these kind of things are there and the cost is coming low and a better quality, obviously that affordability and this thing will increase and it will reach to more deeper into the market.
Understood. Understood.
Thank you.
Also one more question on that. Oral semaglutide is already, available in India. So in your view, it is good enough to replace the injectable one for most patients?
It depends actually. Oral you have to take every day. Injectable you have to take a certain frequency. So we have to see like which kind of patient we are dealing with. The patient can be more comfortable with the injectable depending on their oral compatibility. The tablet size little bigger. Like for some patient find it maybe a little bigger. They are more comfortable with weekly once injection and done for the week. So depending on patient's situation, patients if they are missing the doses in between, then it will be a problem with the oral. So
Okay,
injectable.
oral
So
is
we have to Yes,
injectable
so we
is
have to check.
convenient in that sense. Yeah,
Yeah, we have to check the status of patient also, like which kind of patient is taking, and then better to prescribe. Yeah.
perfect. I think we can end now. It was a wonderful session, and I thank you so much, Dr. Shalu. Thank you also, Mr. Unikrishnan, for coming and giving this presentation to us, giving a very detailed presentation. Also, the Q&A session was very impactful. So I think so that yeah, we can end here, and yeah, hopefully we can have more sessions like this, everyone. Thank you, Mr.
Thank you very
Dr.
much.
Shalu. Yeah,
Thanks, Aryan. Yeah.
thank you, everyone, for attending this session. We can end the event. Yeah,
Bye.
thank you.